Okay, so now we're going to talk about your patient assessment. We always start with our scene size up. You need to make a decision whether this is a multi-system trauma patient. Are we looking at level one trauma center criteria, or is this just some form of isolated injury? As an EMT and advanced EMT, you also need to seriously consider paramedic backup. Paramedics can do things like hang vasopressor drips to increase blood pressure, do advanced airway management, and those kind of things. And look at your mechanisms of injury, and this is where you need to be familiar with those high risk mechanisms that we talked about in chapter one. Does your patient meet the criteria to be a critical trauma patient based upon mechanism of injury? And also, do we need to do full spinal immobilization based on that mechanism of injury? Um, so you want to manually stabilize the C-spine in the neutral inline position. And that's just where you hold the head straight and don't let the patient move the head. You are stuck holding C-spine until the patient is fully immobilized on a long spine board, or with a KED, but you have to maintain manual C-spine until mechanical C-spine is obtained. You don't want the patient moving their head and those kind of things. Manage your life-threatening injuries, your airway, breathing, circulation, your disabilities, exposure, extenuating bleeding, those kind of things. We want to make sure that we're managing those first in the order that we've taught them to you. And, you know, once the spinal cord injury occurs, there's not a lot we're going to do about it in the field. Our job is going to be to prevent further injury, and that's going to be by managing our airway, breathing, and circulation very, very aggressively. Use the ABPU scale to evaluate and monitor level of consciousness. That's alert, verbal, painful, and then unresponsive. Alert, they'll be up talking around. Painful or verbal is you walk up and you go, hey, sir, are you okay? And they talk to you. That's verbal stimuli. Painful is your sternum rub or pinching the nail bed, and unresponsive is no response to stimulus. Um, Unresponsive patients with any form of trauma you should assume has a spinal cord injury, so you're going to fully immobilize those unresponsive patients. Manually remove any large debris from the patient's mouth, so you want to clear that airway. Suction if you need to move secretions, blood, vomitus, or anything like that. Use the draw thrust maneuver to open the airway. We do not do a head tilt chin lift in our trauma patients because that can cause spinal cord injury or worsen that injury. So we're going to use our jaw thrust. Um, An intact gag reflex is a contraindication for oropharyngeal airway. So if they don't have a gag reflex, put an oral airway in. If they do, stay away from those oral airways because you'll stimulate the gag reflex. Patient will vomit, aspirate, and die. A nasal airway should not be used if there's a basilar skull fracture or a suspected basilar skull fracture or nasal trauma. And that's something to kind of keep in the back of your mind. And the reason that is because if there's a basilar skull fracture and you run a nasal airway up there, it can actually go through the fracture and end up in the brain. And that's just not good. So we want to make sure that we're not using our nasal airways in our head injured patients. They got raccoon eyes, they got battle signs. Stay away from those nasal airways. Just do the best you can. Um, Ventilation in context of head or spinal cord injury. Evaluate the patient's breathing. Look at rate, depth, symmetry of each respiration. Make sure it's adequate. You want to ventilate the patient to maintain a end-tidal CO2. We typically say between 35 and 45. There are some situations where the patient's herniating with dilated pupils, posturing, that you would ventilate and run that CO2 down to 30. Um, and we used to call this hyperventilation. We did it a lot, and we found out that we were so good at it that we were causing vasoconstriction to the point that we were reducing blood flow to the brain. Yeah, we were reducing intracranial pressure because of vasoconstriction, but we were reducing the amount of blood to the brain to the point that the brain could not perfuse itself. So we want to be really careful with our ventilations and maintain that capnography between 35 and 45, and in severe posturing patients, it's okay to go down to 30 with the capnography, but don't let it go below that point. Circulation and volume resuscitation in a patient with a head injury. We do CPR just like we would on anybody else. We want to do volume resuscitation, and we want to maintain a systolic blood pressure of at least 90 if there's no uncontrolled, internal bleeding. Maintaining that blood pressure of at least 90 systolic, and some books even say 100 systolic. You just want to maintain a really good systolic blood pressure, 90, 100 or so. That way we maintain that mean arterial pressure of 70 to 75 to perfuse that brain. Um, Assess your radial pulses. Absent radial pulses, you need fluid. Present radial pulses, you need to prepare, but you don't need to give your fluid boluses. We lose radial pulses with a systolic blood pressure, somewhere around 90. So if the patient has radial pulses, that means their systolic is above 90. If they lose those radial pulses, that means it's below 90 and they're in a state of hypoperfusion and are going to need some fluid boluses. Treat your appropriately, lay them flat, high flow oxygen, those kind of things. Decide early whether to complete a secondary assessment on scene or transport the patient to the hospital. I'm going to tell you, in 99% of National Registry scenarios, you're going to load and go and get off scene. They're not really going to put you in situations to do on-scene ongoing assessments. The quicker you get them to a surgeon, to definitive care, to a neurologist, the better their outcomes are. So you really want to keep that scene time under 10 minutes, and you really want to try to get them to the trauma center within that golden hour, whether that's ground or aeromedical transport. Maintain a patent airway, provide high flow oxygen. Hypoxia is one of the #1 killers in neurological injuries. In supine patient, the head should be elevated about 30 degrees. This will help gravity take some of the pressure off the brain and take some of the swelling off of those areas. If they're spinally immobilized, it's going to be hard to do that. But we're not going to spinally immobilize all of our patients, so we want to try to elevate the head. If they are, if you are doing full spinal immobilization, you can take a pillow or something and stick it under that spine board to kind of elevate them a little bit. Get your history, find out what your chief complaint is. Most of the time it's going to be obvious. Go through your OPQRST on isolated extremity injuries, but try to get a medical history. You want to find out a baseline, a mental status baseline. I've been to people before that have been completely altered and come to find out they have Alzheimer's and that's normal. So you want to find out their baseline and find out how far off from their baseline the patient is. Try to get a sample history if you can. These patients have an altered mental status, probably not going to get a real good history. Get your baseline vital signs so you can start doing your trending. Your critical patients are going to get reassessed every 5 minutes. Your non-criticals every 10 to 15 minutes. Do your manual stabilization and ask the patient not to move. Okay, this will help prevent any further spinal cord injury. Monitor the patient's change in level of consciousness. If you have a drop in the Glasgow Coma score of greater than 2 points, that is considered a serious reduction in status, and that gives you a belief of a serious head injury, serious spinal cord injury. And you can try to estimate the severity of the increase in ICP, and this usually presents itself with the Glasgow Coma score. A drop in 2 points is serious, and the faster those drops are happening, the greater the deterioration of your patient. Attain a baseline GCS, Glasgow Coma score. Reassess it with your vital signs. You should be reassessing it every 5 minutes in your head injury patients, and really document that well. Always use simple, easy to understand terms when you're doing your reports. Don't try to make yourself seem smarter than you are, because it just really makes you look dumb by the end of your report. Expose the patient to examine the spine, and then remember, as you expose them, try to keep them covered to prevent hypothermia. So when you assess the chest, try to cover it back up, and then use your DCAP BTLS. We've talked about what that means. Deformities, contusions, abrasions, punctures, penetrations, burn, tendons, lacerations, swelling. Make sure you're able to memorize that and rattle that thing off all the time, because during your trauma assessment you will use DCAP BTLS, and you will have to tell the examiner what DCAP BTLS stands for. So A spinal cord injury may also produce pain of movement or palpation. Um, there are some incomplete spinal cord injuries that allow for different sides of the body to move. Just know if there's any deficit anywhere, we're suspecting a spinal cord injury. Evaluate the chest and abdomen using your DCAP BTLS, expose, inspect, palpate, auscultate the chest, and then you want to check the abdomen for tenderness, rigidity, and distension. Like we said before, there's not a lot we're going to do for our neurological injuries other than manage airway, breathing, circulation, and C-spine and rapidly transport them to the hospital. So internal and external bleeding is going to kill the patient way faster than that spinal cord or brain injury is. Listen to your breath sounds. Also note the rhythm of your breath sounds or your breathing. That will kind of, if you're talking about Cheyenne-Stokes or Cheyne-Stokes or apneustic respirations, and if you don't know what those mean, you need to go look them up. Those are indications of brain injuries. Use your monitoring devices to quantify oxygenation and circulatory status. Also, you want to correct that oxygenation and circulatory status as soon as possible. Monitor the cardiovascular system for signs of shock. Your high T-spine, high C-spine injuries, those are going to put you in neurogenic shock. So you want to be mindful of that. And your patient may be breathing because of, the diaphragm can be paralyzed, but the chest muscles may still work. So you may have some shallow or inadequate breathing. So make sure you're paying really close attention and make sure you have adequate breathing. Check the GI system. Not going to be really effective if the patient has an ultravental status, but you do want to palpate and make sure there's no internal bleeding. And for all of your ultravental status patients, always, always, always check a blood glucose. Okay, so your diabetics of your ultravental status, you will always check a blood glucose on. Reassess your patient every 5 minutes and note their mental status. Make sure you're doing your Glasgow comas every, time you do vital signs, which would be 3 minutes or 5 minutes on your head injury patients. Check your vital signs every 5 minutes. That way you can get your trending. Spinal cord injuries are responsible for neurogenic shock. Also produce flaccid paralysis and complete loss of sensation. So, just be mindful of that and just know that they're not going to be able to feel, so you're going to have to kind of be their advocate to keep their arm from getting pitched in the stretcher. Make sure you're keeping them warm, and they're not going to be able to help you move. Shock is associated with pale, cool, clammy skin, and we get that from the blood loss. And, you're going to have your tachycardias, your tachypneas, those kind of things. With neurogenic shock, we don't get the tachycardia because the kidneys can't be stimulated to release the epinephrine. Treat your patient with a head injury according to the main principles we use on most of our other patients. Get an adequate airway, maintain that adequate airway. Control bleeding, provide adequate perfusion. Okay, you don't want drops in blood pressure. Adequate blood pressure maintains cerebral perfusion. Start at least one 18 gauge or larger IV, so a 14, 16, or 18 gauge IV, and have your normal saline ready for administration, which means you have it hanging and you have it running at a KVO rate. Should the patient need a fluid bolus, you're ready. All you got to do is reach over and turn that clamp up. Preferably, we want 2 large bore IVs, so that's 14, 16, or 18 gauge IVs in big veins with fluid KVO. And if we need to give our fluid boluses, we just reach up there and open them up, and we can bolus the patient pretty quickly and pretty effectively. Get your patient's baseline level of consciousness and constantly evaluate level of consciousness. Shock that has developed in a patient with a head injury is probably a result of hypovolemia. You're not going to lose enough blood in your brain to cause hypovolemic shock, so there's bleeding somewhere else if the patient's in hypovolemic shock. Administer glucose to head injured patients only if hypoglycemia is confirmed by a blood glucose analysis. We typically don't like to give sugar to patients with head injuries because the increased sugar of the level of the blood causes the brain tissue to necrose as it crosses that blood-brain barrier. It can cause harm to the brain tissue. So we want to avoid high levels of glucose in those patients because of the damage that can be done to the brain. So infuse your isotonic crystalloids for hypotension. That's your normal salines. Monitor the patient's blood pressure. Do not allow the patient to become overheated. Hyperthermia is more dangerous in a head injury patient than hypothermia. We don't want the patient to become either, but be careful. Hyperthermia causes severe damage and will cause a worse injury. So scalp lacerations, really quick. These are lacerations to the scalp. They'll bleed. Okay. Every red blood cell counts, so we want to stop the bleeding of our scalp injuries. And this can be accomplished by some 4x4s and some gauze. Doesn't take a lot of pressure to control these, so you're not going to need to apply a whole lot of pressure to the scalp. Just a little bit of manual pressure will usually control your scalp lacerations just fine. To immobilize the C-spine, stabilize the head and trunk so that fractured bone fragments do not cause further damage. You do this with a C-collar along spine board. Maintain your C-spine. Do not move the head any further in case of muscle spasms in the neck, increased pain with movement, numbness, tingling, weakness in the arms or legs, compromised airway or ventilation. So if you go to maintain C-spine and you're causing further harm, stop. I've been in situations where the patient couldn't lay down flat to go on the spine board because of a slipped disc, so we put them in a KED, a Kendrick extrication device, and transport them sitting up. So you really just have to basically do what you got to do and improvise with some patients. C-collars provide preliminary and partial support. Notice you still have to hold C-spine with a C-collar. Really, we put it there just to remind the patient not to move their head. Assess pulse, motor, and sensory before and after putting the cervical collar on. Maintain manual support until the patient is fully immobilized. Okay. What fails most people at registry is forgetting to assess pulse, motor, sensory before they splint, before they do C-spine or any of those procedures. You want to check pulse, motor, and sensory to make sure you're not causing more harm. There are several types of backboards. The most common one is the wooden backboard that you see here. You have to have at least three straps: chest, pelvis, and legs, plus the heading, the headbed to hold the head, the cervical immobilization device, the CID. But you have to have at least 3 straps, and they actually recommend that you do a spider strap or something like that. But 3 straps is the minimum that's allowed. They have vacuum splints and things like that, but the spine board you see is what you're going to see on most ambulances. That's a Kendrick extrication device. We use it as an improvision device and also for our stable, 100% stable, seated patients that have a possible spinal cord injury. If they're trauma, multi-system trauma, they have a risk of deterioration. Not going to use the KED. You're going to go to a rapid extrication with a long spine board. But for your stable patients, you'll use the KED. And we remember the straps. My baby looks hot tonight. My for middle, baby for bottom. Let me kind of draw so you understand. My for middle, baby for bottom, looks for the leg straps, hot for the head, and tonight is for top. Okay, and that's the order that you will apply the straps, and make sure they're good and tight, and the wings sit right up in the armpits. And they're going to be tight. The reason we do the top strap last is because we want it good and tight, and we don't want to compromise respirations. So we do that strap last. Splint patients, 4-person log roll is an ideal procedure for moving patients from the ground to a backboard. And that's where you have someone holding C-spine, 2 or 3 people doing the log roll, 1 person on the spine board. Slide them up in a Z pattern if they're not exactly centered. That means slide the patient straight down and then straight back up while kind of moving them over to seat their head in that CID. Scoop stretchers we use a lot of times for pelvic fractures. We do not log roll a pelvic fracture. And then they have the scoop stretcher with the vacuum mattress. And what the vacuum mattress does is it goes, you roll the patient onto it, zip it up, and it kind of suctions them down and creates a full body splint. Also, a long spine board, when used correctly, is a full body splint. So once they're on a spine board, you won't need to go back and splint them. Seated patients use a short backboard or a vest type. That's your KEDs that we showed earlier. Extrication device to immobilize the C-spine, thoracic spine. Use these in only patients who are stable that will not deteriorate. Use rapid indication if the patient is unstable, there's a threat to life, or limb, or you have to get to someone who is more critical. Then we'll do our rapid extrication. When treating a patient wearing a helmet, you want to know, is the airway clear? Are they breathing adequately? Can you maintain the airway with the helmet in place? Can you get the face guard off? Okay. And how well does the helmet fit? If the patient has a tight fitting helmet to where you can manage the airway, leave the helmet on. Okay. If you can get that face shield off, manage the airway, and a football helmet with football pads will put the patient in a neutral inline position. So if you can manage the airway, leave the helmet on. If the patient can move within the helmet, you're going to have to take it off. Okay, you need a nice tight fitting helmet. And can the spine be immobilized in the neutral position with the helmet on? If the helmet fits well, prevents movement, you can manage the airway, get the face shield off, leave it on. If you have to remove the helmet, you're going to do it very carefully. This is a picture of when we would leave it on. Face shield comes off, you're able to manage that airway. Okay. Motorcycle helmets have the face shield or the covering. What you want to do is, this says consult with medical control, but you need two people. One person is going to maintain C-spine from the chin part of the head. The other person is going to pull the helmet to widen it up a little bit and gently slide the helmet off. It is a two-person technique. So you got the person managing C-spine here from the front. They're pulling the helmet out at the flaps and gently pulling it up to remove the helmet. Use as little force as possible. Make sure all the straps are undone before you move the helmet. Pop the jaw pads out of place using a tongue depressor on football helmets and other helmets. That'll give you more room, requires less force. Place your fingers inside the helmet during removal. A lot of them have little holes on the side that you can put your fingers in and pull apart, and then gently slide it off the patient's head. The person at the side of the patient holding the head will hold the jaw with one hand and the occipital with the other. So one hand on the jaw, one hand supporting the back of the head. The person at the side of the patient controls the head by holding the jaw with one hand, the occipital with the other. Insert padding behind the occipital to prevent the head from falling backwards if you need to. Remember, we want neutral inline position. Small children may require additional padding to maintain the neutral inline position. Padding is very important when you maintain the airway. And on kids, because of their big fat heads, you want the padding under the shoulders to allow the head just to slightly rock back, and you want to line the ear up with the shoulder. Okay, that is neutral inline position. And make sure you use your padding. Place blanket rolls between the child and the sides. Look, they're not going to fit on there real tight, so make sure you have padding around them to keep them straight and flat and actually accomplish spinal immobilization. Back pain is one of the most common physical ailments. Upright posture places a substantial amount of weight on the lumbar spine. This pushes down and causes back pain. Spinal tumors can also cause pain and debilitation. Lower back pain is typically idiopathic, and idiopathic means they just do not know what causes it. So look at your patient's medications and see if this back pain is normal, and ask them, do you have tumors in the spine? Those can metastasize and cause all kind of pathological spinal fractures and spinal cord damage. Degenerative disc disease, that just means those discs are breaking down, which makes the spine more susceptible to injury. Herniation may be caused by trauma. We see this a lot of times with lifting injuries, and that's just basically a slip disc where that soft pad in between begins to herniate out. We typically do palliative care, just try to make the patient feel better, take them to the hospital, and let them get some pain management